Dear colleagues, let me inform you in the chat that we are already live. And welcome to this webinar, to this EUROPREV and EQUIP webinar, a joint collaboration. And I also have with me our speakers for this evening. We have Eva Arvidsson, our colleague in Stockholm, Sweden, and also Piet, Vanden, our colleague from Ghent, Belgium. Hi Eva, hi Piet, how are you?
Hi Carlos.
Hi, I'm fine. I have to tell you I'm not in Stockholm, but anyway, I'm in Jönköping.
Okay, I'm sorry.
It's far more south. No worries.
You know, it's easier to tell Stockholm.
Yeah, it's easier than Jönköping, so it's fine.
Okay.
Somewhere in Sweden.
Okay. How is the weather in Jönköping?
Yeah, it's a little bit cold, not too cold, but chilly.
Do you have snow or not?
No, no snow.
Okay.
No.
And in Ghent, Piet?
No snow neither. A little bit of rain, but it's all right.
Okay. Yeah. Okay. So what are we going to talk about today?
Well, the topic is measuring prevention.
Okay.
So we are talking around that. We start with a little bit about prevention. What is prevention? And then about measuring it. Why would we measure? And about indicators that we use when we measure. And then a tool for measuring, audit. And then we give a few examples.
Okay. Thank you, Eva. So, dear colleagues, we are going to have some questions in our televoting platform, and I already shared the first question, so you may already start answering. And Eva and Piet, we are receiving some good evening messages from different countries. For example, Emily says hello from Germany. Patricia says, good evening, everyone. Looking forward for the webinar. Rosario Falanga, good evening from Italy. Marina, good evening from Bosnia and Herzegovina. Good evening to you all. So I would like also to inform you, colleagues, that for those of you that want a final certificate of our 6 webinars, this is the last webinar of this year. You will have to do an attendance check. How do you do it? I will share through the platform at the end of the webinar or at the middle of the webinar a link where you can go and fill a form, putting your data, your email, so that we can then see if you attended at least 5 of our 6 webinars. For those who attended at least 5 of our 6 webinars, we will send them during the next 2 weeks, more or less, a certificate of attendance of our webinars. Okay? So we are receiving more good evening messages. Maria Bacola, hello from Ionina, Greece. Anna, hello from Austria, Österreich. Pavlo Kolesnik, hello from Ukraine. Hi, Pavlo. Irina, hello from Ukraine also. Daniela, good evening from Romania. So we have colleagues from all over Europe.
That's wonderful.
Okay, let's now look to the results of our first televoting question. And at the same time, I will activate already the second question. Okay. So that you can already answer also the second question. And the first question was, what is prevention? And 11% of our colleagues answered to prevent people from getting sick. And 89% answered both. Do you want to comment on that?
We will come to it in a minute, but I would say it's both.
Okay.
Yeah. I agree. Mm-hmm. Yes, and it's even more than both, but okay, both is all right.
Okay. And then we have the second question, and the second question was prevention includes measures aimed at the population. Another hypothesis B was measures aimed at an individual, and the last one was both. And 100% of our colleagues answered both.
Oh, yeah.
That's great. That's good.
That's wonderful.
Okay.
I fully agree.
So I think we can now start with the slide number 5. What prevention?
Yeah. So that's a little bit what you already answered. And we just wanted to tell you what prevention we are talking about. And I'm sure most of you have seen, if you go to number 6,
Yes.
you have seen this picture with a waterfall. It's a lake on top, and then like a little river, and then a waterfall. And people start in the lake, they fall down the waterfall and get hurt. And down there, where the people are picked up and saved and maybe fix their broken legs and whatever, that is care of sick people or maybe tertiary prevention. But if we move upwards, upstream, we could stop them from falling by putting up a net or catching them before they fall, and that might be secondary prevention. But we could also go all the way to the lake and do primary prevention, which might be to keep people on shallow water so they don't float away, or even teach them how to swim. And the whole idea is, of course, that the earlier interventions, the cheaper it would be, and the more health we would gain. So that's number 6. And then number 7.
Okay.
Shows the same thing. What are the different levels of prevention? Primary prevention with healthy people, secondary prevention, which is about early disease, to prevent early disease from getting worse. And then the last level, tertiary prevention, which is preventing people who are already quite sick to get even worse. And then number 8, slide number 8,
Okay.
primary prevention. There are some examples of it. What you could measure is both health promotion and disease prevention. And examples of this is vaccination and child and maternal care, anti-smoking campaigns, and so on. And slide number 9,
Okay.
secondary prevention. That is, as I said, treating early disease. So it could be early treatment of diabetes or treat high blood pressure before it becomes something worse, like a cardiovascular disease, or screening for cervical cancer, so you can find it early and treat it before it gets a problem. And then number 10, which is when you come in later and treat a disease and prevent it to be more complications, or even rehabilitation could be included here. So it could, for example, be laser treatment of eye complications to patients with diabetes, and so on. So these are the 3 levels.
Okay.
And if you click again, both secondary, you get that little circle that shows that both secondary and tertiary prevention is both prevention, but also to treat and cure. So at the same time as it's preventive, it's getting worse, you treat the disease that's already there. So it's a little bit mixture of prevention and treating for those 2 levels. And then number 11, which is kind of the same, but divided into population and individual. And population-oriented prevention, it is the type of primary prevention I talked about before, maternal and child care and vaccinations and things like that, that aims for a big population. While the individual prevention is what could be called a high-risk strategy, where you try to find individuals and work with them lifestyle intervention for a certain disease. For example, getting a patient with high blood pressure to start doing physical activity or reduce alcohol consumption and things like that. So these are two population and individual oriented prevention. So that is just an introduction about what we are talking about, different types of prevention. And then number 12, why should we measure it? And after that, I think we come to your next question, Carlos.
Yes, okay. And I have already shared in the chat information that we had a new question. And the question is, did you ever measure prevention? And we have a 50-50 answer. 50% of the colleagues said yes, and 50% said no.
That's interesting.
Yes, and now looking forward to the next question and the answer there, especially from those who already experienced it.
Okay, dear colleagues, you may already vote in the next question. Is it easy to measure prevention, yes or no? And while we wait for the answers, I will share one or two comments that we received in the chat from the colleagues. For example, Anna said, hello, why cervical cancer screening is considered secondary prevention and not primary prevention?
Well, of course, it could be discussed, but I think what you look for is early, now I don't know if I know the English word for it, but it's already started to be abnormal. So you're not trying to prevent the infection from coming. You're trying to prevent what is already some disturbance to develop into full cancer. So it's pre-canceral cells already that you find in the smear, pap smear.
Mm-hmm.
Then we have another question from Marina. What about quaternary prevention?
I was expecting that question, and I think it's a good one. And of course, well, all we are doing might be looked at as being preventive. And I think within EQUIP, we are very concerned also by overdiagnosis and the risks of prevention and getting overdiagnosis. So I think I agree that might be the fourth level we should add, no doubt.
Okay.
Yeah, overdiagnosis and overtreatment, but maybe we can have that's some other seminar. It's a big topic too.
Yes, we had a lot of debate in EUROPREV in our network about these topics, about the different levels of prevention and also about the quaternary prevention. And we also had a publication last year in the European Journal of General Practice, where we proposed a review of the concept of quaternary prevention, proposing it as an action taken to protect individuals, persons, patients from medical interventions that are likely to cause more harm than good. And in this paper, we also presented the different levels of prevention, and so I will share with the colleagues the link in the chat of this paper, and you may also have here a complementary read to these definitions of the different levels of prevention.
Well, and I would add, within EQUIP, we look at the same problem with the same, perhaps the same angle or a little bit different. We look at it from the point of safety, and overdiagnosis is really a big safety issue. It's causing harm. From that point, it's really something we should look at. Okay.
Yes, overdiagnosis, but not only overdiagnosis. For example, if we have some treatments that may provoke, or that we know, or we have evidence showing that the probability of doing harm is greater than benefiting our patients, then we should be aware of that and avoid it. This is in accordance with, for example, many of the recommendations of the Choosing Wisely campaign. For example, doing aspirin in primary preventions for low-risk patients. Choosing Wisely campaign, as most of its recommendations are indeed measures of quaternary prevention. So it fits quite well with that. Okay, Eva, we can now look
what's
to
the answer of
answers.
that
Yes,
question?
okay. So the question was, is it easy to measure prevention? 97% answered no.
Okay.
Well,
So that's a challenge for us to see if we will make it easier or more complicated.
You have to convince them.
Yeah.
Yes. Because we are convinced that measuring prevention is one of the easier ways of the easy things to do in measurement. Okay.
Okay. Just a few seconds. I want to ask my technicians, are we having problems with the connection? Because some colleagues are telling that the video is jumping. Okay.
We have some low connection sometimes, and then maybe it stops a little bit.
Okay, but is it working now? Yes? Okay, we are online. So, dear colleagues, yes, we had a slow internet connection for some minutes, and that's why the video jumped. But we are trying to establish it again, and I think we are live now again. Okay, so please, Eva.
Okay.
Or
Slide
Piet.
14. It's
14 was the question, so now we are
15.
on 15.
on
Okay.
15 already. Okay.
Why measure prevention?
Okay. So why measure prevention? Well, I think there are a lot of reasons why you could measure. I think the three most important, in our point of view, are you can measure to know what you're doing when you are working in your practice, and to know what's the amount of prevention you're doing and how good you're doing. The second possibility is that some people ask you to prove what you're doing with all the money they give to you, and how you can show that in measuring prevention, for instance, you're doing a fine job. But the most important one, and the one we are emphasizing on, is that you should measure to improve, to make sure that you can look at what you're doing and you can reflect on that, and if necessary, make it better. And I think that's an essential step to be able to improve, is to start by measuring it.
Yes, and then number 16.
Okay.
Can quality really be measured? It is difficult to measure real quality. If you take some tools, whatever it is, and try to measure communication, empathy, contact between the doctor or the healthcare provider and the patient, and try to make it into figures and put it in some kind of diagram, it is impossible. It will not show the truth. It just shows a small part of the truth. And then if you click,
Yes.
what we can measure is quality of simple things. And there is an example of blood pressure there on the picture, but even blood pressure, it's difficult. You can have all types of problems measuring blood pressure, which you probably know, all of you. So even things that seem to be easy and measurable are not easy. So that is one thing we have to have with us when we try to measure prevention.
Okay.
And the next slide, number 17, is also about the same thing, that we are going to continue talking about measuring. But before that, there is also qualitative data. We can gain data from having reflective discussions, organizing focus groups with patients or staff, making interviews, or have simple questionnaires. And we can ask patients and staff and leaders and other people that make a difference in primary care, and find out things that we can't find out when we measure, as we're going to talk about from now on. So we might need both quantitative and qualitative data when we want to find out about quality.
18.
18,
Okay.
yeah, it's
Eva,
yes,
you may drop your microphone. We can hear
okay.
you well. you
Can you hear me now?
you can
Okay,
rest
sorry.
your hand.
Okay. Okay, sorry. So the next one, it's a little bit the same as Piet said, that we measure for different reasons, and measure for improvement is what we're going to talk about, and the middle one, accountability. That's what I guess what Piet called prove, to compare, to show what we are doing, and maybe also to be inspired to make some changes. And then there is measuring for research, which maybe quite a few of you have knowledge about, or maybe even your own experience. And sometimes we mix up measuring for research and measuring for quality improvement, because you need to do it in different ways. You have to bear in mind that it's not research we are doing now, it's quality improvement. So if you click again, you see the red little square around that.
Okay.
And then if we move on to number 19,
Okay.
even with improvement, there are different reasons to measure. And one reason is to find out, what do we need to improve? To get an overview of what we're doing, maybe in many fields or maybe in one field. But see, what is our biggest problem? Where should we start? And the second reason is to follow an improvement project to see how it's going. Maybe we made some change and we want to see what is happening now. Is it getting better? Are we improving? So these are two different reasons to measure for improvement. And if you click again,
Okay.
for both of those, we can use indicators to measure.
Okay.
And then 20, we move on to indicators.
Yes.
Thank you, Eva. Well, indicators. What's an indicator? Let's start with a definition, and please, Carlos, give me the next slide for that.
Okay.
There is a definition. It's a definition we had for a long time and still are using in EQUIP. And well, an indicator is a measurable element. It's something you can measure. And Eva already said you can't. There are a lot of things in the practice you can't measure. But if we talk about indicators, if we talk about measuring quality, it's about a measurable element of the practice. The practice performance most of the time. And it's interesting to have indicators, and the most interesting indicators are those where there is evidence or consensus that it can be used. And I think that's a fault often made. That is that we start with measuring things on which there is no consensus or no real evidence. And if there is no consensus within the practice about something you're doing or you want to do, then there will, if there is no consensus, that will be very difficult to measure and to have all people participating in a correct measurement. So make sure to discuss those indicators and to make sure that you agree on them, that they really can assess the quality, and if you want to change, hence change in the quality of the care you provide. So I think this is a definition which we will continue to work on a little bit in the next slide, please.
Okay.
So an indicator is always a fraction. It has a nominator and a denominator, okay? What's above the line, what's the nominator is, well, for instance, the smokers or the people having a disease or the people receiving a certain treatment or participating in the preventive act you're doing. And the denominator, which you also should look into, is which might be very important also, is well, the population in which you are measuring. Okay, so often it's logic. It's all patients. I want to know all smokers and my patients, for instance. Well, okay, but that might be far more difficult, and it might be far more interesting to say, well, which are the people with the highest risk when they are smoking? It might be my COPD patients. So perhaps It might be a far more interesting indicator if I focus on my COPD patients and having the smokers there. And start from there on, and perhaps start with those COPD patients and later get a broader view of other patients on my practice, because I learned with those COPD patients how I could use this indicator. So you can have all patients, you can have specific age groups, you can have patients with a certain chronic condition, but it's smart and important when you start reflecting on measuring, that you start to reflect on this dominator. Within which group will I start to measure? And then afterwards decide on the denominator within that. You understand?
Okay, yes.
Okay, let's go to the next slide.
Okay, 23.
Yes. So there are a lot of indicators, and you can find a lot of indicators yourself, or you can find them on the web, or you can find them. But if you have a list of indicators, to make a selection and to think, to reflect on what are the good indicators, the one I want to use in my practice, you have certain features of them. And the first one is perhaps the most important. Good indicators should be valid. That means that it really measures what you want to know. And it covers well what should be measured. That seems very abstract, but you can find easily some examples on which you can discuss about validity. I give you an example I often use, and we have done even workshops with that. But for instance, HbA1c. Is this a valid indicator for my care for diabetes? It's a question we didn't ask you because it's not really about, well, it could be in secondary prevention, for instance. But I can answer you, well, if you have a good result, what does it really mean? It could mean a lot of things. It could mean that you have selected the good diabetic patients and just measured them and forgot the others. So you could have a problem at the denominator side. It could also be that you have a lot of early onset young diabetes patients, and that all the old diabetes patients are treated by the specialist, for instance. So this is an indicator which you could discuss about validity. It really tells us how good we are treating our diabetic patients, yes or no. I hope it makes it a little bit clearer. So the second feature of a good indicator is that it's objective. That it's something you can really measure, and that's not subject of interpretation. Okay, and also that's not always so easy. Okay. The third one is it should be feasible to do it in the practice. It should be easy to find or to measure, so that you can really find out within your daily routine what you're doing, and not something that you have to do several other things or look into it more in detail before you can really say this or that is the value of my indicator. A fourth one is it should be discriminative. If it can't show any difference between the good and the bad practices, why should we measure? Another example on that, if you ask patients how good their GP is, I can tell you in all practices, I think all over Europe, nearly all patients will say, well, I have a fantastic GP. So if we measure the quality of GPs by asking patients what they think of their GP, we might have a fantastic result, but it's not discriminative at all. We can't compare colleagues and the quality of practices in between one another by asking this question. So a good indicator is also influenceable. If I change something in the practice, you should see change in the indicator. It should be easy to explain to your colleagues, to your patients, to the people when you come with your results, and it should be accepted by the patient and by the team who is looking into these indicators. So this is an impressive list, and what I advise is when you have an indicator and you have an idea of an indicator, then you'll put the list next to it and you say, well, this indicator, what do we think? Is it valid? Is it feasible? Is it objective? Might it be discriminative? Is it influenceable? and can I communicate and easily explain and will be accepted by my team and my patient. And in that way, it can help you to decide on which indicator to take and which not to take.
Piet,
Yes.
is there any kind of library of indicators that GPs could consult about different topics related with family medicine? Indicators for diabetes, indicators for hypertension?
No. Not that I know. It's not that easy, because a lot of indicators also are contextual, meaning that it might be interesting and easy to do it in your country, might be far more difficult to do in another country. A lot of indicators are based on the guidelines. And since guidelines might be different from one country and one place to another, the indicator might also be different. So there is not really a library, but one of the things you can do is when you look for indicators on a certain topic, to ask about in other countries, for instance, if they have any indicators. We did that last month. We did such a survey on indicators for the treatment of insomnia, which is, for instance, it's quite interesting to see how in different countries they have different indicators. But bringing them together and then deciding for your own practice, your own country, is a way you can progress.
Okay, okay. I may share with you that in the Portuguese health system, we have, for example, a public document that lists all the indicators that are used in primary healthcare in Portugal, and they are more than 365 indicators from different areas, different clinical topics, and so on. And I may also share that also in our health system, we have the Ministry of Health very often publishes guidelines about different clinical topics. And usually at the end of each guideline, it has a set of indicators accompanying this guideline that may be applied related with the guideline.
Wow.
Can I comment on it?
Yes,
please.
If you move on to number 24, so I think it depends a lot on the purpose. All these qualities that Piet talked about for indicators, they might be more important if you measure to compare what I called accountability and what Piet called to prove, to show that one practice is better than the other, or to compare with each other. They are really useful for that, and then they have to be discriminative. But if we measure for improvement at our practice, it's different. So I think all these qualities on indicators, I think now we are talking about measuring prevention for quality improvement. But if we measure prevention to see, do you work more than with prevention than I do, or your results better, then it's different. Then we need to have different indicators and also different qualities.
That is a really important remark and comment. I thank you. For example, those indicators that I was talking about are not really okay. They are aimed to be for quality improvement, but they also are for the Portuguese pay per performance system, and also for comparing the work of primary healthcare teams. Yes. So I think that is a really important comment that you did.
It's absolutely a very important discussion, and I should go a step further, Carlos. One of the important things is these indicators can only be accepted if you as a GP group agree on them and participate in the development and in the development of them. If they are just from the government put there and said, well, these are now the indicators, then it's not acceptable. That's one. And the second one, Eva, you can perhaps comment on, is on this pay for performance thing. Eva, do you want to comment on that?
Yeah, we talked about that, I think, a little bit last time. EQUIP wrote a policy paper on using indicators for pay for performance, and it's on the Wonka website and also on the Equip website, and the conclusion of it is that it's not a good idea. It doesn't really improve quality, but it has a lot of negative side effects using quality indicators for pay for performance. So please study that paper, and I'm sure you can send out the link to that too, Carlos, if somebody wants to
Yes,
have a look at it.
I am just
It's also
Googling
published
for
in
it.
yeah, it's published in an article too.
Yes.
So it should be possible to find, or I can send it to
Okay,
you.
I will try
But
to
I
share
think that,
it in the
yeah,
chat in few minutes.
we talked about in Equip, we talked about calling quality indicators
It's from
different things.
2017, isn't it?
Yes,
Measuring
yes,
quality in primary care,
yes,
Equip position paper. Okay,
exactly.
it's here. I will share it in the chat.
Very good. Thank you.
Okay, thank
So
you.
we talked about calling indicators, quality improvement indicators for the ones that are made for quality improvement, and maybe some other quality checking indicators, or, just to make the difference and to make it clear.
Yeah.
And when we use them for ourselves, we can use any indicator that we think is useful.
Yeah. Okay.
Okay, so we move on.
Yes.
Yeah. Which slide are we on?
24.
We are on 24, and if you click one more, the two questions that I had before are there again. So now we are talking about these two purposes. What do we need to improve, and how is our improvement project going? These are the two purposes we're going to talk about now.
Okay.
So if we move to 25,
Okay.
there is the first of these questions. Indicators when we want to know where to start to get an overview. Then it's good to have some indicators that show the width of what we are doing. Maybe on a lot of different topics we can measure. If it's prevention, we can have something on primary, something on secondary, maybe all the levels of prevention, including the last one with overdiagnosis, and maybe different topics, different diseases. And if we can see both, maybe compare with other practices, but also compare with ourselves over time, we might see, oh, here is something that we don't have so good results in. Maybe this is something we need to improve. I made a little red square around one of them where the little red dot is under mean. Maybe that's something we need to work on. So having a width of indicators to see, get an overview and see where to start is useful. And if you click again, it comes up, follow over time to do it systematically. And that is really the best if you have a chance to follow things and see how are we going. Is it something where we are dropping down, where we used to be good, but this year it's not so good anymore? Maybe we should have a look at that and so on. And then number 26, the next purpose, how is our improvement project going? And this is the PDSA cycle, and we are not going to talk a lot about it, but I just wanted to point out, if you click again, that if we decide something, this is an area where we need to work. Here we have a problem. Then we start to look at the problem, making a problem analysis. What are the different reasons? Why would we, for example, have worse results this year than last year? What happened? What do we need to change? And then maybe we have some ideas for change. And then if you click again, we pick one of these changes and decide that we're going to test it for a limited time in a small scale. Maybe a few of us test, or maybe all of us, if we're in a group practice, test for a couple of weeks, but just a small scale test with one idea of change. And then if you click again, we need to measure. And here comes the measuring to see how our improvement project is going. So we need to have some kind of baseline measurement when we see what is our level now. And then if you click again, we can see that when we did the intervention or the change of some kind, are we getting better? Are our results improving?
Okay.
And if you click again, the last part of the PDSA cycle is to decide, looking at our results, our measurement, did it go well? Was it a good idea? Was it a good thing we changed? Did we improve? Then we should adopt that thing and not only test it in a small scale, but start using it, all of us, maybe permanently. And if it wasn't so good, results were not what we hoped for, then we have to adjust and maybe make in a different way. Or maybe we reached partly where we wanted to go, but not all the way. Then we might have another idea of something more to do to improve our results. And then we test that and do the whole cycle again. And the measurement for improvement to see how our project is going, it is just to follow up and see, is our improvement project moving in the way we want?
Okay, but how? I think next slide. Yes.
Yes. Pick a project.
Yes. How do we find the project we really want to start with in our practice? That's I think also an important question, because you can put a lot of energy in it, and well, it's good if you put the energy in the right thing. Don't do a lot of projects at the same time. Start with one at a time. I think that's a very important one. Take some time and do one at a time and learn from doing it, because it's really something you should get experienced in, and start with a simple one. Okay, so how do we find ideas to pick a project? You can brainstorm with your staff, or something could have happened in the practice which didn't go well, or which was very good on the other hand, and which you want to continue, or which you want really to avoid it because it hasn't been good. There might come new rules, there might be something in the media, or there might be a new vaccination, or well, whatever, a new idea. So there are a lot of ways you can find ideas about which projects you could go on. Some students can come into your practice and make a remark and say, well, in another practice I saw them doing that or that, and you could say, well, that's a good idea. How could we organize this in our practice, for instance? But if you have a lot of ideas, and I hope you can have a lot of ideas in this way, then it's about how do we choose the right project to continue with. And there are also some very simple ways in which you can do it, and it's about cost benefit. So let's have the next slide, please.
Okay, 29.
If we look into the costs, well, the cheaper it is, the easier to do. Okay, I hope you all agree that we live in that world now, and I think it's a good quality bottom line. But cost is not only about the money; it's also about how difficult is it to start. How do we have a low threshold? Do we easily can adapt or change something? Is it easy to do it as a project? Are we able to do it in our own practice? Because if you want to change something in which you need specialists or the population or the government to support you, then it will be far more difficult, you realize, and you perhaps have to wait for opportunities before you can do it. So things you can easily do in your own practice are also at a lower cost. The less time it takes, the better and the easier it is. And if you have valid indicators which can help you to measure it easily, it's also something you can put into the cost-benefit analysis you're making. And if you have a lot of motivation of the staff on a certain subject, that's also something which can help you to decide on that. On the benefit side, the next slide.
Okay.
It's also important to look at that. If it's cheap and it realizes a lot of health benefit, then perhaps it should be the first project you choose. So what is having a lot of health benefit? Is it something frequently? Is it something serious which you can do a lot better? And is it something which you can effectively change? Then I think you have more chance of being successful in your project. So where can we have the most improvement in the whole project is the one. So, and it's this way of looking at cost and benefit that helps you to choose in the right way. So I'll resume it in the next slide. So if you have a problem that is frequent and that is serious, that's of great gravity, and your solution is feasible at a low cost with little secondary effects and little effort, and if it's seen as a priority by the people involved and acceptable for you as a team and for the patient, then I think you have the perfect project to start with. I don't know, Carlos, if there are questions about this or any remarks on that?
Not so far, no.
Okay. Well, Eva, I turn over to you again, because now we are
number 32.
choose our project. How are we going to find the
So this is the data collection, and this is when we come back to indicators, I guess, or measuring. And we are going to talk about audit, and sometimes there is a little bit of confusion about what is audit, because it's used in many ways. And one way is just generally audit and feedback, which I guess is what pay for performance and those type of measurements broad are about. You collect data, you report it back to the GP practices, and you hope that they will improve. And that could be done small scale, but also big scale. It doesn't have to be connected to money. It could also be that somebody measure and you report data back, audit and feedback. And there is some studies on that. I just wrote a few references down there. So there is a Cochrane systematic review on using audit and feedback for quality improvement. So that might be interesting for somebody to read. Another thing that some people mean when we talk about audit is what is called Audit C, which is a screening tool for alcohol use that the patient can use themselves, or we can use it with the patient. And there is a reference for that too, if somebody wants to look at it. And the audit we will talk about is just a simple method of data collection. So if you click again, there will be a red square around that.
Yes.
And then another question to our participants.
And we have already answers, 38%. And colleagues, I will already activate the next question because it follows already this one. But to the first one, have you tried an audit? If yes, what type? 38% answered never tried an audit. 32% answered audit and feedback. And then 26% answered simple data collection, and only 3% answered Audit C.
Okay.
Great.
Okay, now we have to wait a little bit to receive the answers to the next question. That will be, do you have electronic medical records? Yes, partly, or no? Okay, here we have...
Yeah, we wanted to know that because it's a little bit important when we talk about or collect data. So we thought it's interesting to know.
It's much easier, isn't it?
It is. But we're going to talk about how you do it without. If somebody don't
it depends on the software you have, because
yes, that's true too.
And on the user of the software.
Yes.
What is into the software? That's perhaps the most important one.
And the permission that you have to analyze the data, because sometimes you have the software, it allows to collect data, but you don't have authorization to do it. It's also a problem.
Yeah, it can be different legislations, and some people can't get it out of the software, even if it's all in there. So there are a lot of problems.
Okay. We may now look to the answers. 64%, 65% now answered yes. They do have electronic medical records. And then 24% answered partly, and 7% answered no.
Okay. So we have all type of users, and probably what we just talked about, that some might have it, although it's difficult to get the data they want out of them. So if we move to 35, Now we're going to talk about audit, easy data collection, which is a kind of survey to find out things you want to know about your practice. So slide 36. An audit design, it can be prospective or retrospective. And retrospective means that we look backwards. I think you all know that. So you stand where you are now and you look at your data backwards. Maybe you can see if you can get it out of your medical records. And of course, if that's easy, you will get a lot of answers relatively quickly. So that's an easy way. But on the other hand, as we talked about, it might be difficult to get out what you need, depending on all these legislations, but maybe also on how it's registered. If it's not registered in a structural way, it might be very difficult to get the information out of the medical records.
It's one of my experiences. If we start with the first time with doing an audit, most of the time the only result is that the practice should start to agree on how to register in the medical files to easily get out the data you need. And even if that's the first result, it's the first circle you're making, it's a very important one to be able to continue and to measure afterwards in an easier way. So it's an important one.
If you click again, that little blue square comes up. And I think, Piet, you're right. I think that almost everybody's first experience that we couldn't get it out. Next time we have to register in a different way so we can get it out of our system.
Exactly.
But then you talked about before, how difficult is it to register and so on. It has to be balanced, but still. If you click again, it comes to prospective, meaning that we look forward. So we decide that from now on, we're going to collect data. And that, of course, takes a little time because we need a few occasions, a few patients, or what it is we're measuring. But you can ask the questions you want and you can get the data you want. And we also have to be aware of that once we start measuring, we will also change the result. If we, for example, measure how often do we talk about tobacco use with our patients, and for each patient we make a little mark if we talk about tobacco. But then after we started to measure, we will maybe be more concerning more about talking about tobacco with our patients. We don't want to have bad results, so we think about it a lot more and do it a lot more. But then on the other hand, again, that doesn't matter. If our purpose is to start to improve on talking about tobacco with our patients, then the improvement already started. And it's not research, so it doesn't matter that we affect the process, but it's good to be aware of it. Okay, number 37.
Okay.
When we make the form for the audit, it has to be easy. It has to be easy to fill in. I tried a few audits where you just make a little bit too many questions, and then you don't even have the energy yourself or the time yourself to fill it in because it takes too much time between the patients. There should be just a few questions, and it should be really easy to answer. Yes or no, or maybe a number, or maybe very short text, but very easy to answer. And it's usually good to have somewhere to write unknown or irrelevant, and maybe also to write a comment in the form. And once you constructed a form, it's good to make a small pilot that you can make with a few patients, a few of your own patients maybe, or ask a colleague to test on a few of his or her patients and see if it works. And then, Piet, you suggested that you really measure how long time does it take for each patient. And if it's more than a few, like 20 seconds or something, then it has to be reduced because otherwise you won't have time to do it when you get busy. And sometimes it's easier. You might want to do it directly into the computer, into Excel sheet, so it's easy to use. But usually it's easy to do it with a paper and a pen that lies right beside you. It's quicker than moving around between different programs in your computer. So our suggestion is to do it on paper anyway.
Yeah. Eva, I want to stress on this slide. I think this is the slide which you really have to use when you start doing an audit, to look on that. It's very important. This is the way you make it feasible to do it. If you don't do it that way, you will get problems. Keep it simple, keep it fast, and then a lot of people can participate. But if it's too big, you will get problems that
Is
you
it
will
really
have. Yeah.
is it really possible to have this kind of forms that are filled in less than 20 seconds per patient?
Yes.
Yeah, we have some examples, so I hope you will
that
agree
is
with us.
astonishing.
Yeah.
But I want to emphasize on that. Really, 20, 30 seconds is the max. If it takes more time for you while you're doing in your practice, seeing patients all the time, you won't take the effort to do it because it takes you too much time. Or you do it sometimes yes and sometimes no.
Of course, of course.
Often we try to think, oh, we're going to ask about this and that, and this is interesting and that is interesting, and we add question after question because we are so curious of everything. But then it won't work. So keep it simple and accept that you can't get all the answers in one audit.
Yeah, and also if you just have to put in a little circle or a yes or a no or one or 1, 2, 3 or 4 or 5, it's a lot faster than having to write something down.
Of course, of course.
So the way you present it is also a way in which you can gain a lot of time.
Okay. Interesting.
Number 38. Now we're moving to the example. So here is an example. Let's say we want to know, is smoking a problem for my patients? I really don't have any figures of how many smoke or not smoke and how is it. So maybe I decide what I need to know is something about the patient, age and gender. And then I want to know if he or she is a smoker, never was, or is an ex-smoker. And here again, you could ask how many cigarettes and this and that, but make it simple. Here are 3 different answers. And then maybe something about comorbidity. Do they have other chronic diseases? No. Between 1 and 2, or it should be 3 or more. I think that it's written in the wrong way. No. Maybe you want to know something about socioeconomy about the patient, and then we use today's problem. But that you could skip that. That might not be important to have. And then if we go to 39, here is how it could look like. And this could be printed out on a paper, and you fill it in for each patient. So if you look at the first white line there, the first patient was 69-year-old male. He was a smoker. He had 1 or 2 chronic diseases. And there is just a little exclamation mark on socioeconomy, meaning that that is an issue for this patient. And he came today because of an injury. Okay. And the second patient, age 52, female. She's an ex-smoker. She have a few chronic diseases, and she came for a check of her blood pressure. So you fill in just 1 line for each patient, very fast and easy. And in the end, you have some information.
Less than 20 seconds, indeed.
Exactly. And then you can do it. Even if you think you're so stressed you don't have time, you can do this. It's quick. But then after doing that for, let's say, a week or a couple of days, you will have some idea about what does it look like? How many smokers are there? And what do they come for? And what type of patients are there? And then you can start thinking about or talking with your colleagues. What can we do about this? What is the problem about?
Yeah. Or you can choose which group do we tackle first? Are it the patients with chronic diseases, for instance? And so you can decide on where is the biggest problem and then tackle that first. Is socioeconomic status one of the important things here? And well, if it is so, it could help you and say, well, okay, let's focus on this group of patients, for instance, or don't focus on this group of patients on the other hand. So it's helping you really to make an inventory, how to start your project and to decide on which priorities you will set afterwards.
Maybe it's those who patient with injury and cold, those that somehow just come on like emergency or drop in or something, and
Yeah.
you don't. Maybe you have to focus on those, how to get them back and talk about tobacco.
Yeah. Or talk to all patients with a cold about tobacco, because that's the moment in which they might be open for it.
Yeah. Okay.
Okay.
40.
40.
It's another example, and this could be either to find out if we have a problem with blood hypertension, or maybe to follow up a quality project that we already started. Maybe, let's say we said we need to improve the number of patients that reach blood pressure targets. And we could measure how many do have pharmaceutical treatment, and if so, what type of treatment or how much, and what about lifestyle for the patients. And if you click again, there is an example of a form for this. Patient number 1, do he or she reach the target? Yes for yes and no, N for no, or question mark if we don't know. Do they have more than one medication? Maybe you should have 0 and 1 or more. But in this case, it's only more than one medication, yes or no. And then do they have lifestyle problems? So the first one, don't reach the target. It doesn't have more than one medication, so 0 or 1. And the patient also smokes and have a problem with physical activity and have a problem with alcohol. The next one, reach the target, don't have more than one medication and have a problem with alcohol. And you fill in for each patient. And the same way, you decide about which columns to have here, what to measure, depending on what you think is a problem. And in this case, you might see that, there are some lifestyle problems, then maybe we need to know more about this. So maybe we have to make a second audit where we find out more about alcohol, since it seems to be a problem. Now it's only 2 patients, but if we had a long list where that was a problem. Or maybe it's about medication. Maybe we don't give them enough medication. Maybe we should look at those that have only 0 or 1 type of medication. Maybe they need more. So we can find different problems and different things we might want to study and move on. And we can also use it to see, if we measure again, to see, do we reach the target for more patients than last time? Or do we have less lifestyle problems this time than before we did whatever intervention we tried? So that is one other example. And then if we move to 41, it's a little bit about what type of things we can measure. And number 1, structure. If you click, there comes up yes, no.
Yes.
So these are all things that is connected with quality. And one is structural things, that is equipment and staff. And sometimes that is useful to measure. Do we really have the chance to do this? Do we have resources? Do we have time, for example? Yes or no? Do we have a person who is educated in this and could actually help patients? Do we have the knowledge? And it could be yes or no questions, or maybe if it's time, it could be number of hours or something. But it is, do we have the things we need to give this quality? Number 2, if you click again, is process. And things about the process, I think, is what we used mostly in audits. It's about the things we do, the activities. And it could be numbers of days waited if people wait too long. And it also could be number of treatments, number of medications, or number of investigations. Things that we do and have a connection with the disease or the problem. And the last thing we can measure is outcome. If you click again, that is the results of healthcare. And usually we have to measure surrogate, is it pronounced like that, surrogate measures?
Yep.
For example, who quit smoking or who started to do daily exercise or who reached the target for blood pressure. The real outcome, do they get healthier or do they die later? We can't measure. That's too complicated. Sometimes we get into discussions about measuring real outcome, but for quality improvement and especially for prevention, it takes too long time. And we already know that a lot of the things we do are useful and do help the patients. We don't need to measure if they get healthier from stop smoking. It's enough to measure that they stop smoking.
Can this be a problem if you want, for example, to submit a project after doing it and for publication? The kind of outcome that you chose, the fact of choosing surrogate outcomes, can it be a problem or not, in your experience?
My answer is no, because if you do research, you have to measure in a different way and do it in a different way. And then you don't want to figure out, for example, if quit smoking is a good idea because we already know it. So in this case, you want to find out, do the interventions help your patient? And if you do a quality project working on that, you can publish it in a quality improvement journal, but you can't publish it as a research project on outcome.
Okay.
I think that's, Carlos, that's an important pitfall. This is all about quality improvement. It's not about research. So there is no ambition to do any publication except for yourself, to show it to your colleagues in your practice or to another practice, but not to be published in an international journal. If you want to publish something in an international journal, then indicators are different, methodology is completely different and far more complex and difficult to obtain.
Okay, thank you.
But you could publish it in, for example, there are magazines or journals, international journals on quality improvement, BMC quality improvement, and you can publish a quality improvement project and describe how you did it, what your results was, and your experiences and things. If it's something they think is interesting enough to publish.
Yeah.
But then it's not research, as Piet said. But you can publish it.
Okay.
And then you often will add qualitative data and having some interviews with the people who participated and adding this in a way that you describe the process you have done and the results and how you obtained the result you have.
Exactly.
Okay, thank you.
Okay, so 42. It's one more example. This is sleeping problems and alcohol, and this is something we discussed, how to discuss alcohol or find out about how do we treat these two problems together. So it's similar, not so many questions, a little bit more questions this time.
Maybe more than 20 seconds.
Maybe, but most of them are yes and no. So yeah, it might be more than 20 seconds. So if we just have a quick look at the first row, the patient is a female, 69 years old. And the main reason for her visit, was it sleeping problems? Yes or no? No, it wasn't. It was back pain. So we're feeling no, and we're feeling back pain. And is it a new problem? No, it's happened before. We know about this problem. Comorbidity, we could have just yes or no, but in this case, we filled out diabetes, heart failure. And then all these questions about alcohol. Did I talk to her today about alcohol? No. Did I talk before? Yes. Does she have a risk use? Does she use too much alcohol? No. And then the other questions are not relevant because it's not a problem. The second patient, a male, 52 years old, he came for sleeping problems. And it is a new problem that we haven't talked about. He also has a depression. We fill in that under comorbidity. And we talked about alcohol today, and we have talked about it before. And he used too much alcohol, but still we didn't give any advice, and I didn't give another appointment for the patient because he said, I don't want to talk about this right now. He's not motivated, and maybe I will talk about it next time. I will try to remember, or I will see him later, but that is why nothing happened this time. So this is a way to find out about alcohol discussions with people with sleeping problems.
Eva, how can we use this kind of form to improve quality? Well, I'm not seeing how we can use it in a practical way.
Well,
this one about sleeping problems and alcohol.
Oh, you don't think you thought the other one were more useful than this one, or you mean in general?
No, I mean this one. For example, in this one, if you could give a concrete example of quality improvement, I think it would be helpful.
I think that at least I and my colleagues often don't talk so much about alcohol for patients with sleeping problems. And maybe we don't talk about alcohol enough for a lot of our patients. It's a little bit difficult if they don't bring it up themselves or if it's not obvious. Then maybe we talk about other things, but not alcohol. And then we miss it out. And then maybe an idea is to follow up. Why don't I talk about it? What happened? And maybe I should have a line here also saying that I didn't feel like it, or I didn't bring it up because I felt uncomfortable, or other reason why I didn't talk about alcohol. But I think that is a problem. And in this case, the idea was to learn a little bit more about why we not talk about it. In my practice or in my work, we can take out some figures on how much we talked about alcohol because we have some other indicators. And it is a problem that we don't bring it up enough.
Okay, interesting. Thank you for the example.
Okay, so I think the next one is the last example, and this is an audit that we did many years ago when we wanted to find about asthma patients. And I brought this here mainly to show you some diagrams made out of it. This was to see how many patients that that's got urgent care for asthma the last 12 months. And to find this out, we had to find the asthma patients and then look up in the medical records if they had been there the year before. And usually that wasn't registered as asthma, it was registered as a cold or something. But we could see that we had treated them as asthma, so we could understand that still it was asthma. So we made this audit to see also about smoking. And here we don't ask if they smoke or not, but when we looked back in the records, was it possible to find at all in the records if there were smokers or not? Was it documented in a way so we could find it? And as you can see, it was just written in the text in a lot of cases. Somewhere it was written, keep smoking or something, and it was almost impossible to find. So we needed to improve on that. The next one, if they have an inhalation steroid, and the last one, if they did a spirometry. And then if we look at 44, these are the two diagrams we made out of that. And there are a few more diagrams also showing about smoking and stuff. But this is just about how you can get an illustration of your situation, because this was done in a lot of practices. And each blue bar here is one practice. Okay. So the ones to the very left, they had very few patients that came for urgent care for asthma. And the ones to the right, including the red one, they had many patients again. I think the one far out right was at 100%. I think they must have made a mistake when they filled in the form. But you can see there is a big difference, some having a lot of the patients and some very few. And then together with the other indicator, the one on the bottom, the ones who had spirometry. Spirometry, at least here in Sweden, we will try to do spirometry regularly on patients who have a little bit severe asthma at least. So spirometry would be an indicator of patients who came for a regular checkup. So in this case, we can see that the practice who have many patients coming for urgent care also had very few patients who came for a regular checkup. So probably they have to figure out how are we actually doing with our asthma patient? What is our problem? Do we know how to take care of asthma? Do we teach the patients enough? What is our problem? And it might be very different reasons. But this was to show how you can do diagrams out of your questionnaires, out of your audit forms.
Okay, I think this is really interesting and a good example. And if we may recall what Piet presented about the indicators. So now in this example, we have seen the form to collect the data to do the audit. And now we have these two diagrams with, I think, I am not wrong if I'm saying this, that each one of these diagrams corresponds to one indicator.
Yes.
Yes. Mm-hmm.
Yes, okay. For example, the percentage of asthma patients who had urgent care due to asthma in the last 12 months. This is the indicator. The denominator would be... I am lost now.
The denominator is the asthma patient. The denominator is the asthma patient. All the asthma patients in your practice.
Okay, and the numerator would be asthma patients who had urgent care due to asthma.
Exactly.
Okay.
Yeah. So out of all asthma patients. And the other one is the same, that out of all asthma patients, but here instead, how many had spirometry?
Okay. Okay. So we have integrated all parts. Okay.
Yeah.
Eva?
Very good remark. And then when we have this, the next step is to go to the PDSA cycle and see why do we have so many that comes urgent and what can we do about it?
Okay.
Okay. So number 45, when we do an audit for quality improvement, we don't need to have that many patients or that many days of collecting data. Sometimes 20 is enough if we see that it's the same problem with all of them. Let's say that we did the blood pressure form and we see that none of the first 20 will reach the goal for blood pressure, then we'll probably have a problem without doing another 20. But maybe we need some more, maybe up to 60 for practice. But it's not research, so you don't need to have hundreds. It's not like talking about significance and stuff like that. It's to see a trend, to get an indication of how it is. We could run the audit. Maybe we decide we run it for a week. If our group practice, everybody try to fill in with all their patients for a week. Then maybe we think, this is not enough. Let's do next week too. Or maybe we see that, we should have one more question, or that question was too difficult to fill in and we need to do some changes. So yeah, the sample is an indication. And if you click again, there is just to show that you can make it really, really simple too. You don't have to make it on the computer. You can make it really easy and just fill in with, I don't know what these are called in English when you make
it's tufting.
What?
It's tufting.
Tufting
bars. Tufting.
Okay. Thank you.
Yeah. It's really easy. It's the most simple way of starting an audit, but you can easily do things like that. Yeah. But I think if the examples you gave, most of them you can easily do on paper and are easily done on paper in a prospective way than if you have to do it in the computer. So
yeah. Okay, number 46. It's the same study as I showed you before of different purpose of measuring. I just wanted to point out this again about the sample size, that just enough data. It's not research. We don't need a lot of data. I think that is a trap that a lot of us would step into and think, this is not enough. We don't know if this is the real truth. No, but it's enough to know that here we seem to have a problem. Okay, 47, and then it's Piet, if you want to comment on the process.
Well, I want to continue a little bit. I hope you see if making it a small set of indicators and making it a small sample is a way in which you can really make it a lot easier to measure and to have the messages you need to start improvement. So if you really then want to start the improvement and starting by measuring, I think the whole measurement also is a process. So to be successful there, a little some tips. Make one person responsible, and he can after one day, for instance, when you say, well, this was the starting day, he can send a reminder to everybody and ask, is everything going well? And if you say it's for more than 1 week, he can repeat that every week and ask colleagues in between and at the coffee, is it working? How are you doing? And if necessary, if it doesn't work, just stop and rework the audit form until people say, okay, I can do it now. So I think that that's very important to have somebody which is coordinating, stimulating, and taking up responsibility to do it. The same person or somebody else can, after the audit is finished, gather and process the information. And if you do so, keep statistics very simple and relevant. Again, it's not research, it's just to show what you're doing. And you can reflect a little bit on how can I present my results in a way that's understandable for everybody and that you really see what is happening or what we did. And in that way, you can start with improving quality. And I think Eva already said, and I want to stress on that, if you start improving, then you have to do a new audit sometime afterwards, after 3 months or after a year, to check, do we really see that it's better? And if so, what was the reason why it's better? If not, what were the barriers? And can we tackle those barriers and restart again? And since this is with small samples, with easy indicators and a fast way, it's easy to redo the audit again and to make this comparison. So I show you one example from our practice, which is about tetanus vaccination. So we started a project. It was a student of us who came into the practice who did this project. And we agreed on writing a letter to all patients who were 25, 35, 45, 55, and 65, to tell them, well, how is it with your tetanus vaccination? Do you know anything? Did you get vaccination? How long has it been done? Should it been renewed? So the idea was within 10 years we would have the whole practice population, which was feasible for that, and we just have to send, well, perhaps every month 20 to 30 letters, something like that, and the computer helped us with that. So what we saw is in 2017 we received answers from, or we had a sample of 90 patients, and of them we had about 22% of them of which we knew on beforehand already how their vaccination status was, and we found it in our medical record. We had, by writing the letter, another 20% of people getting a vaccination, and then we had a small sample who got it in the hospital or got it from at work, and we still remained with a lot of people not answering to the letter we sent. And then we saw in 2018, the next year, that things were starting to get a little bit better, that the already known, you see how registering and starting and having a better register already makes sure that you know a little bit more. So this enhanced from 22 to about 30, 35%. And we vaccinated less because already more we knew about. And we knew also more about people who were elsewhere vaccinated. And in that way, you see how you can start with a very small project on enhancing vaccination status for people in your practice in a feasible way and measuring that. Okay.
Okay.
Back to you again.
Yeah. So the next one, 49, is just showing what Piet just said, that we measure.
May I share a question?
Yes.
Okay. About the sample size, Antonio asks, but in that case, if you use a small sample, couldn't we risk taking biased conclusions on non-representative samples?
Yes, the answer is yes, in one way. But on the other hand, it really doesn't matter when it's about quality improvement. It doesn't have to be perfect data. Of course, it can't be completely wrong, then it's useless. But we don't need to have the issues about having a really big representative sample with no bias and statistics and all these things. So a small sample, there's been studies, I don't have a reference right now, but showing that a small sample is really enough for quality improvement.
Okay.
To see the trends with a few.
Can you give some examples of numbers?
Well, I want to continue that. It's I think there are some small tricks to try to avoid that. For instance, one of the tricks is that you make sure when you start with measuring that you measure everybody who is coming in and meeting the criteria and not selecting patients. This one I want to put on and this one not. So this is, for example, a strategy in which you say, okay, we start today, and from today on, we do it for 2 weeks, and every patient with hypertension, we will put him in.
Okay.
Then you have less chance of getting bias and still having a small sample. So reflect on that. It's a good question to avoid it. But you can find easy solutions to not make sure, but to have an acceptable way of having a good sample.
Okay.
Even if it's...
And could you give you or Eva some examples of numbers? When we talk about this kind of samples, are we talking about 50 patients, 70 patients, 100
yeah,
patients?
something like that. Maybe 50, less than 100. If I do on my own practice, I think just measuring is important because we don't know if we don't measure. And usually we think we do things that we don't. And once we start measure, we see that, oh, this one doesn't reach the, for example, blood pressure, doesn't reach the target, and not this one either, and not that one either. And we see there are quite a few just in a couple of days, and we realize it's a problem. Or if we make an audit on what type of antibiotics we use, for example, we will see that there are quite a few occasions when we don't use the recommended antibiotics. And then we can already start working on it without having a perfect, non-biased representative sample.
Mm-hmm. We did it for hypertension, and we just said the first 20 patients you as doctor see with hypertension. And we were 4 doctors, so we had 80 answers for our practice, and we had 20 answers for each doctor, which made it possible to compare between one another and have a whole sight of what the practice is doing. So small samples often are more than enough.
Okay.
We usually had, like you said, Piet, 20 per doctor, and if we are a few colleagues, we can add it together. If you do it alone, maybe start with at least 30 if you work alone, 30, but not so much more. You will see a trend.
Yeah.
Okay, we don't have a lot left, so I'm just going to go. The next one, 49, is just saying test again. Sequential tests, meaning test again and again to follow what's happening.
Okay.
Not just once before and once after, but keep checking how are we going. And if we finish the project, keep measuring. I'm sure you will have another figure for tetanus 2019, Piet.
Yeah,
to keep
it's not
following.
there, but, we have it. Of course, we have it. Yeah.
Yeah.
Mm-hmm.
And
yeah,
the next.
We did, for instance, for the feet examined in diabetes patients, we have a sequence of now about 25 years.
Yeah.
Mm-hmm. Yeah, in which we every year look, do we test do we look at the feet of our diabetic patients, and you see it going up and then going down, and then we have to do something to get it up again.
Mm.
Yeah.
And I think that's important too, the difference from research when you do like one large test. You measure before, and then you do like a perfect sample and a perfect test, and then you measure again. But this is not research. We're trying to improve bit by bit.
Yeah.
So number 50 is just to remind you on that is what we are measuring. How is our quality improvement going? And it's a circle that moves over and over again.
Okay.
So then we come to 51, which is our conclusion number 1.
Yeah. Well, let's start with me. So we think, we know, we are convinced that measurement is the start, is the basics for having good quality improvement. Without measurement, you can't improve quality. So just start measuring and do it in a simple way to learn how to do it. About your practice performance, you will have some ideas when you start with doing that, and how your improvement process is going. These are the three reasons why you can do it, and I think there are three important reasons, but our advice is just start with an interesting first idea, do it in a simple way, and step by step, do it at a time. Don't do too many measurements at a time, because then it gets too complicated and you won't have time to process the results and discuss on them. And then
Okay.
next slide.
52. Yeah, we already
Okay.
said this a few times now. Small samples, not too many patients, repeated measures, and allow yourself to adjust on the way. It's quality improvement. You can change. The purpose is to get better, not to have data that you can compare with something.
So
Okay.
I hope I have convinced some of you that measurement of prevention is perhaps not that difficult, and that within next year, if we do a new measurement and we start asking it again to you all, that instead of 97, we get at about 50% telling us, well, it's still difficult, and the other 50 saying, we did it.
Yeah.
Okay, I think it was quite interesting and practical. So with this webinar, and the webinar will be available so that colleagues can see it again and again whenever they want. If they have any doubt, it will be available in EUROPREV and EQUIP websites. So dear colleagues, you may use it whenever you want. I have here some more questions from Antonio. He wrote, thank you for your comments and tips, very valuable. What types of data do you search for in electronic medical records? Free written text, predetermined fields? Who collects the data? Each practitioner for their respective patients, and he is also concerned with data safety concerns.
Well, if I start, I think that the last one, data safety, of course, there have to be regulations, and that might be different in different countries. In my country, we are allowed to search data for quality improvement without an ethical permission. If we do a research project, we need ethical trial to see that if we're allowed. But for quality improvement, we can search data for our own practice, not other practices, but my practice can me and my colleague search. And usually not free text, at least we can't do it. We can mostly search things that have a I don't know what you called it, but a fixed, it can be like smoker or non-smoker or something that is fixed values on. And then we can search numbers like blood pressure, diagnosis, and number of visits, and last time we saw them, and a few things, but not free text. And who can take the data out? That depends. Some colleagues are really good at it, most are not. You can ask somebody who knows how to do. And in some places there is some secretary who had a special education and can help. And at some regions, for example, when I work, we have some people employed in the region that can help the practices. But that is also different in different places.
Okay. Well, I want to add some comments on that. First thing on privacy, you have to make sure that when you gather the data, you don't put names of patients anymore. You just put ages and gender and things like that. So that's the first one. The second one is quality improvement, in my point of view, is part of the daily work of a general practitioner. Your patient is entitled to the best care you can give him, and your population is entitled to the best care you can give. So you should do quality improvement in your practice. It's in my point of view, it's one of the daily tasks you have to do. So you don't ask permission to some university center or whatever, or ethical other body to do your daily work every day. No, on the contrary, you should ask not to do that if you think you're so good that you don't need to measure. So I don't agree with you with people telling that there is a problem with that. As long as it stays within your practice, it is confidential, and it's not about the name of a patient, but it's about the statistics of the group of patients you're looking at. That's one. The second answer is just a story. In our practice, normally it's the nurse who is doing the analysis of things like that, and she's coming into the group when we meet, and she's bringing the results, and that's kind of an exams results for all GPs to see if they are doing well and if the practice is doing well. And that's a nice way of doing it. She's experienced, she's doing it very well, and she stimulates us all to do it better.
Thank you. Eva, I think you have last slide.
Oh yeah, that's maybe a little bit for fun. It's actually something my son and I talked about. And, you know, whatever you try to do, quality improvement and also other projects, it takes time. And he's old, he's an adult, but he said to me that I found out that you should take the time you think it will take and multiply it with pi. And that is closer to the real time it takes. And then a couple of weeks later, he said, oh, I revised my formula. If you click again, you have to take the time you assume it will take and then multiply it with pi square. And that will give you a better estimation of how long time it really takes. So that is just to encourage you that if not everything goes smooth all the time, it takes a little bit more time, it gets small complications. Don't give up, keep going, and you will reach some good results, I'm sure.
Okay, thank you. Very nice way to say it, with a positive message. Well, I would like to remember our colleagues that I have already shared in the web chat the link to make the attendance check. Okay, so you have, if you are interested in receiving a final certificate for attending our webinars during this year, this one is the last one in this year, you may already make these attendance checks by clicking in this link, and then you will open a Google form and just fill it, and it's done. And I ask you to give us some time. I will probably send you the certificate during the next 1-2 weeks. Okay, so I would like also to thank Piet and Eva. It was really interesting. It was really nice to be with you tonight. And once more, it was our second webinar. It was for us really a very positive experience. And in name of our colleagues that were attending all over from Europe and even from some countries outside Europe, a big thank you for everything that you shared with us. And I will now give you also the word to say goodbye to our colleagues. Okay,
Carlos, I want first to congratulate you with this fantastic initiative and with the way you are doing it. It was for us an honor to participate, and you came up with the idea to do this together, and I think it was a brilliant idea, and I hope we can continue in the future to participate and to do things together, because thank you for that. Really, it gave us an opportunity to show and to spread our ideas, and on behalf of EQUIP, congratulations again with your fantastic webinar. Thank you for giving us the opportunity to share and to participate. Okay, I thank you, and I would like to comment on that also.
It was for us, EUROPREV network, really a positive experience of this joint collaboration with EQUIP, and it's true, it was also very important for us the support that you gave us from the first moment that I talked and shared this idea with you. You said immediately, yes, we will be interested in participating, and that was also very, very important for us. So thank you. And about next year, I am already receiving some comments and some colleagues asking if we are, even in our Facebook, some colleagues during the last days sent us some message asking if we are going to do more webinars during the next year. Okay, we haven't decided yet when we will do it. Probably yes, we will do more webinars during the next year, but we have to fix dates, speakers, the program. So there is a lot of work to do. I think I will start organizing it during the first months of the next year. And it's also important to have your the support of our colleagues, because everything has some costs. For example, I have an audio technician, a sound technician in the room. I have 2 cameras. I have almost a professional studio in this room, and this has some costs to EUROPREV. And so we have opened our individual EUROPREV network membership. And for all colleagues that may be interested, you may join our network and also receive a certificate of being an individual member of our network, and also receive our newsletter. So this would be a way of supporting this kind of webinars organization, and we would appreciate it. So now, Piet, thank you once more. And we are also receiving some messages from the colleagues. For example, Emmanuel, congratulations for all the fantastic webinars. Foteini, thank you very much for all the webinars. Were very helpful in our everyday practice. Also from Marcos from Greece, thank you all for the amazing webinar. You are gold. We need to practice now. Carlos, you are a pleasure to hear. Oh, thank you. Thank you. Marina, thank you all for an excellent webinar. I will start and try to do audit. Okay.
Wow, wonderful.
Okay. I hope Carlos will organize another series of webinars. Okay. Giselle from Philippines, thank you so much. A great help. Thank you, Giselle, for being there from so far. And Anna, I have attended all webinars. Thank you. Dr. Vitorakis, congratulations and thank you all. Gazment from Kosovo, thank you all for the amazing webinar. You are gold. We need to practice now. Okay. Rosario, fantastic webinar. Thank you and good night for everyone. Thank you, Rosario, for being there, and a greeting for Italy. Okay, now again, Eva and Piet to say goodbye.
Yeah, thank you so much. I can just agree with everybody who says this has been really, really good. And I especially want to thank everybody who participated and listened and wrote questions and interacted with us. That is really, really good and interesting for all of us. So thank you, Carlos, and thank you, everyone. And thank you, Piet, for doing it together with me, too.
Yes.
It was really a pleasure, Eva. Yeah.
Thank you both. And now I wish you a Merry Christmas. I wish you a Merry Christmas. I wish you a Merry Christmas to you all, dear colleagues all over the world. Piet, Eva, thank you very much. Have a nice evening. See you next time. Bye-bye.
Bye.